welcome to friends and colleagues. Good to see you. We've had a good meeting, and as you're aware, including a number of items from NOM, so we thought better than after jigging in and out that we just all join at this point. I can see the meeting's being recorded for posterity. I don't know if we yet have any members of the public on the call, but if we do, you're all very welcome. We have a formal slot towards the beginning of the meeting where public attendees can ask questions. But in this new age of working remotely, I think it would only be fair and appropriate that we afford you that opportunity again towards the end of the meeting. So should you have any questions, please do type them in, and we will add them up, and we will return to them at the end of the meeting before we close, so that will afford you an opportunity to ask anything you might wish to do. We've got a number of apologies, so I'm just going to go to John, please, for the apologies.
Yes, we have apologies from Anne Margaret, Martin Rose, Mick Portman, Ruth Bentley, Eddie Lewis, Jamie Wright, Keith Nercombe and Judith Rees.
Very good, thank you. And that brings us on to the declarations of interest. We do need to update the register with respect to a declaration from Tom Burton, which we will do. But are there any other changes to the register of interest that we need to be aware of?
Helen, do I need to chip in my bit, or is that for a different occasion?
Well, no, now would be a good time. Okay,
well, I've just accepted an interim CFO position for a company called Millbrook. They provide into the NHS wheelchair services and community equipment services. So I'm working with them for a 6-month basis in the capacity of interim CFO. There won't be any conflict, certainly not with Chesterfield. And if there is, I will obviously further declare any contracts that might be involving Millbrook and or our hospital.
Thank you, Mike. Also, I'm not sure, board colleagues will be aware, but the Council of Governors won't have been advised yet, I don't think, of your appointment to the Board of Rotherham.
Oh, sorry. Yes, of course. I do apologise. No slight intended. Yes, as of the 1st of April this year, I was formally invited to be chairman of the audit committee at the Rotherham Trust the Rotherham Acute Foundation Trust. Can't get my F's right, do apologise. I haven't done very much yet other than sit on a few board development days, and I don't see it as a threat in any way, shape or form to Chesterfield. In fact, I hope it's complementary. I hope I can learn from Chesterfield and take it to Rotherham, and vice versa. If there's any bits in Rotherham that we can pick up for Chesterfield, then I'm sure people would be receptive. So I'm, as a lot of you know, I've had good reasons for joining the NHS in the past, and from what I've seen in the last 12 months during this pandemic and how hard people are working, it's just made me even more committed to try and do my bit. So I promise it won't impact on my ability to perform my duties at Chesterfield, and I hope it will be complementary.
Thank you, Mike. Any other declarations that colleagues need to make? No, can't see any hands. So thank you for that. This is the first opportunity for verbal questions from members of the public. Can I ask you, Gillian, have we got any? Gillian sometimes has, no members of the public as of yet. No, very good. Thank you, Emily. So anyway, we'll come back to that opportunity at the end of the meeting. So that brings us directly to the first substantive item, which is the Chief Exec's briefing. I have trailed, Angie, that as part of your briefing, you're going to share with colleagues thoughts about a kind of roadmap to return to the site. So we're expecting that as well as other things. All yours.
Thanks, Helen. And I'll just give a warning that this morning I've been thrown out of Teams twice. So should that happen, because inevitably it will when I'm in the middle of speaking, won't it? Then I know colleagues can pick up questions and comments for me. And I wasn't proposing to go through the whole of my report, you've got that there, but just thought I'd update on a couple of items in real time, one of which is the Governor roadmap. So in terms of where we're at today, really pleasing to update you all that we've only 2 COVID positive patients in our beds today, one of whom is in critical care, but clearly significantly reduced numbers from the last time we met as a council, and that's really positive for everyone. We've almost 400 non-COVID patients, so clearly lots of activity still ongoing in the hospital, and 6 of those patients are in non-COVID critical care. So I say still lots and lots to do, which I'll touch on in a second. Our staff absence rate again has come down. We're at 4% with 0.9 of that being COVID related, which is really positive. And our vaccination programme, our hub actually closed yesterday in the hospital, so we've done all our second doses. So thank you to the team for completing that work. And you'll all know that across Derbyshire, lots of activity on rolling out the vaccination programme, and we're down to the 45 plus age brackets now, which is really, really positive, and Derbyshire doing some great work there. And gives us all that hope and optimism as the sun's shining that there'll be some sort of normality soon. However, we're not complacent. There are instances of areas up and down the country of where the rate is rising, and in Derbyshire that's in the 11 to 18-year-olds I've heard today, and not actually in schools. So interesting as to where that's those behaviours are clearly not working as well as we need them to. So a reminder for us all and for everyone to continue the practice that we need to keep ourselves safe from COVID. And also the other big piece of work that I've touched on here before, and we regularly do, is supporting all our staff. Our people have been through some very challenging times, professionally and personally, as we all have, and they will continue to do so, and particularly probably more so for some now as we start to come out of the worst of that COVID world. Lots of support still in place for staff as they understand what the impact it's had on them, their colleagues and their families. We had our staff partnership committee last week, and I think a reflection of where we've all been feeling a little bit that morale's not great. I think that is, as I say, that impact of where we've been, and that recognition that there's a huge amount of work to do to support all our emergency cancer and planned care patients. But some of us and some staff are really keen to get back and support, but there's others that are really exhausted. And even though all those positive measures are in place and the COVID numbers are coming down, clearly we've still got to work in ways that support minimising COVID, and doesn't mean by any means that we're back to a normal hospital at the moment. And on that note, I was going to introduce the roadmap that we've worked on for yourselves as governors to get back a bit more on site. And again, it is that balance between giving everyone that opportunity in a safe way, but not going completely back to the way we were pre-COVID. We have got visiting slowly increasing again on site this week, and working on partners for pregnant mums being back at all their appointments. A real focus on that as well this week. What we're proposing for yourselves as governors is that we give the opportunity for you to be back on site for the Councillor Governor meeting. I'm giving Helen the challenge of chairing a meeting that is on Teams and in person at the same time, because I think that's going to be really hard. But we're suggesting that we practice run that in June, early June, so that we can get used to having people in the room and on screen at the same time. The maximum number that we can accommodate in the education centre is 15. So clearly we can't straight away, while we've still got distancing measures in place, go back to having everybody in the room. So we just wanted to ask for your thoughts and give you early warning today, really, to say, can you be thinking about, and we know there's some colleagues who aren't with us today because they don't have the ability to join on Teams. So where we can, those of you that want to and need to be on site, we will support that. There'll be others of you that are more than happy to stay on Teams, and it's more convenient, or you feel safer being on Teams. So if I can just ask you to be giving some thought to that and work with Nick and John over the next few weeks, just to give us an indication. And as we then slowly get used to that mixed economy, we'll keep that for Teams, but for visits and smaller meetings, then we can start to get those back on site. I've now realised that we need much bigger meeting rooms across the whole organisation, but that will take us a bit longer to achieve. And the last thing I just wanted to touch on was the planned care restoration. And Bernice will be joining us shortly, but at the moment she's just working with her system colleagues on what some of the plans need to look like to meet our annual planning targets for this year. I think I mentioned at last Governor's meetings that the guidance nationally was pretty late this year. I think we got it on the 26th or 27th of March for the year starting 1st of April. So clearly we haven't quite got everything nailed down, and there's a deadline of the middle of June to get all our plans pulled together. But the teams obviously have been working really hard in delivering the care for patients, but just trying to work through that balance now of, as we slowly increase the number of theatres we have open, how many elective care operations we can reinstate in what time frame is a very detailed piece of work. And I was going to suggest that we bring that back to next Governor's meeting, because it'll time really nicely with the 9th of June, that's around our submission time. And we can give you all the breakdown of all the diagnostic activity, the outpatients, the operations that we're doing across the whole of Derbyshire to get our patients back into the system as quickly as we can. But that is going to take us, a long time. In Chesterfield, we're quite lucky that we haven't got a huge backlog of patients. It's significant, but compared to our colleagues in Derby, that is even bigger. So we're looking at how we can work together to support all our Derbyshire residents to get the treatment they need as quickly as they can. But for some operations and procedures, we're looking at over a year now to get back to where we were before the pandemic. So I'll pause there, Helen, and happy to take any questions. And if we can save any for Berenice, she'll be with us soon.
Very good. Thanks for that, Angie. You touched on there the whole kind of journey to recovery. And that was a big feature, as you will have seen from the discussion in the pre-meeting with governors and the informal. So in addition to what you've said there, we had a request from Greg that I thought was very sensible, that we bring a substantive paper to a future meeting. And I was saying that you'll be able to do that not only, of course, for Chesterfield, but as the lead for planned care across Derbyshire, being able to put it in that wider context. So I know that will be warmly welcomed in terms of what we're doing, how we're going to do it, and how long it's going to take to get from where we are to where we'd like to be. So I think if we're on the promise of that, that will probably avoid the need for you to say too much more now. But if you could make a particular comment about ENT, because Ruth had a particular inquiry from a constituent about if ENT referrals are an area where there's particular pressure and particular anticipation of delays, if you're able to, please, Angie.
So firstly, we've got some system work on ENT happening, not only system but regionally. So the three specialties that have the highest waiting times in a planned care world, orthopaedics is the biggest. So if you think of all our patients on the waiting list, and those waiting longest, about a third are orthopaedic patients. And then ENT and ophthalmology are the other two specialties. And we're not unique in that in Chesterfield or Derbyshire. That tends to be the national position with a little bit of variation. So we are part of the Midlands elective programme, which is a piece of work that's looking at those three specialties to look at how we can do things differently and learn from other areas. So we are looking at that at the moment. It's very early days, but I'll include that in the presentation I give on the 9th of June meeting.
That's great, thank you.
And if there's anything specific about ENT and a referral into us, then just let us have the details. I'm happy to look into that.
Thank you. Margaret.
Hi, Angie.
Hello.
good to hear that you're thinking about bringing the Council of Governors back onto site for those who would be able to and want to come. I'm also very keen to think about the other things that governors come onto site to do, like the ward visits and so on, and getting back on some sort of track with that. And have you given any thought at this stage, along with practitioner, about when an appropriate time to be thinking about that sort of activity would be?
Yeah, that's from now. So if you can let us know your preferences to who wants to be on site for those and who wants to carry on joining virtually, we'll happily facilitate those conversations. So perhaps if you do that through Nick, and then Krishna and I will make sure we join that up.
Thanks, Andrew.
Very good. And a helpful comment from Lynn, as I think you indicated, Angie, about giving priority to those who can't attend digitally. Yeah. Pervez, please.
In order to deal with the backlog, we will have to work longer and faster, not only on the hospital front, but also in the primary care where these patients will be followed up. Have we spoken to our GPs on this particular issue, if they will be giving up more time in the evenings, the weekends, and in general?
I'm struggling to hear you, Pervez. I think what you're asking me is in terms of, given the size of the backlogs, the expectation that we expect people to work harder and faster, and have we joined that up with the conversations with primary care? For me, it's not about working harder and faster, certainly not in isolation, because the size of the backlog and given the context I set out earlier around our tired workforce at the moment, that's not going to achieve what we need to achieve. There may be an element of that, but predominantly we're looking at different ways of working, and in the planned care group we have GP representation sat on that. So for example, we've introduced a system that one of my GPs fondly calls choose and not book. So you'll all be familiar with the choose and book system that GPs sit with you as a patient and then you choose where you want to go and book in. This is more about how we can work with primary care to give the advice at that point. So rather than automatically book, we can, from Helen team's colleagues' point of view, give more advice and guidance, so we don't end up with automatic referrals. So that's just one example of how we're working with primary care. There's others in terms of work we've done in dermatology to look at different ways of seeing patients in the community before they would get referred into hospital. So lots of examples of that we need to continue to do to be able to address the huge backlogs that exist.
Thank you.
Thank you. We've got David Lyne, please.
Yeah, I'm good.
We can hear you.
I'm here.
Very good.
Good. Asked a question earlier about the position, really, of advice to the public from the hospital. Several of our older constituents, and I'm really one of them, have raised with me to raise with you and Helen about the possibility of some advice. Now, I know that's dangerous, but what I was going to say is at the moment there's a great deal of confusion about the position of the Oxford vaccine. Now, I'm not going to put you on the spot and ask you what do you think, but I'm just wondering whether you could offer some kind of up-to-date thinking from the hospital as to that particular vaccine.
Thanks, David, and I'll put my medical director on the spot instead of me, because he's also picked up a couple of comments around some of the restoration. Thanks, Hal. So if you want to comment on that and then the vaccine, I'll hand over to you.
So I was paying attention, Angie, because I'm busy typing away here at the moment to try to add to some of the other comments. The thing about the vaccine is obviously a developing picture to a degree. From the point of view of hospital staff, and I recognise this won't necessarily be a consolation to governors and the public, but all of the hospital staff have had the Pfizer vaccine to do with the fact that the storage requirements and it having to be kept at minus 70 degrees and things has tended to be secondary care and hospital based. The issue about the AstraZeneca vaccine is to do with the fact that there seems to be an increased risk of a very rare type of venous thrombosis, so cerebral venous thrombosis, which is a very significant and serious problem if people get it. But to give a scale of the risk, it's thought that per million vaccines that might affect 4 or 5 people. That's the current data. So for every million people that get it, it may affect 4 or 5 people. So it's a very rare but serious problem. And I think we obviously have to think of that in the context of the dangers of COVID. And if you're, for example, in your 70s or 80s and you catch COVID, then your risk of dying is probably somewhere in the region of 10 or 15%, depending on other medical problems. So we've got to sort of look at the balance of risk. But that's the reason that there's a suggestion that if you are very low risk individually from the point of view of COVID, so for example, if you were a 25-year-old healthy young adult, then at that point your risk of COVID might start to be outweighed potentially by the risks of the vaccine. And that's the reason that there's been discussion, particularly in some European countries, about people of a younger age not being given the AstraZeneca vaccine. There's also some recent information about, I think it's the Moderna vaccine, isn't it? Is it the Moderna one or one of, no, it's a Johnson & Johnson vaccine, where there may also be a thrombosis risk with that as well. So it may be a more general thing to do with the makeup of the COVID vaccines. I think, having said all of that, any vaccine, any medication has some degree of risk. The degree of risk for getting COVID is very high. The degree of risk for getting a complication from the vaccine is very low. So if you were looking at it, whether from an individual point of view or from a public health point of view, you would definitely be continuing to recommend the vaccination. And I think, to be fair to Britain and the NHS, one of the things that we do seem to be getting very right compared to a lot of countries has been the rollout of the vaccination, and the fact that we've, more than half of the population has already had at least one vaccine is a testament to all of the fantastic work that's been done, locally in Derbyshire and across the country. Does that provide some reassurance, David?
Yeah, thanks very much, Hal. I realise you're not going to write anything which you can sell in the Derbyshire Times and then be proved wrong next week or something like that. I'm not trying to get you on that footing. And I think really you've probably raised the only salient point in that there are very few blood clots, with about 4 deaths per million rather, in the situation where a lot of women, I think, are more concerned maybe than men. And people have also asked me, why then are they introducing the Moderna at the Sheffield arena, which is happening or about to happen, and how does the South African variant effect come into it?
I mean, the Moderna vaccine has only recently been approved, so that's why it's starting. That was always part of the planned rollout. It's not a change in policy. There's some data, as you may know, suggesting that it's more effective against the South African variant for what it's worth, but it's felt that all of the vaccines are broadly effective against all of the variants as things stand at the moment. So I think the right thing for the country is to carry on with the vaccinations. That's not to say that there haven't been problems. I know in Barnsley they have had one of the cases of cerebral sinus vein thrombosis, so it's not that it doesn't exist. I'm absolutely not meaning that, but it is a very rare complication, and fortunately, to the best of my knowledge at present, we haven't had any cases locally. But as I say, there have been some nearby in Yorkshire, so it's a real thing.
I just wonder if you might stick on the theme of vaccines for a moment, Hal, because John Rigglesford raised a question earlier in our informal catch-up. And I just think if we stick with the theme, John, I don't know if you want to ask Hal at first hand now, please.
Sorry, I was eating a sandwich. And that is, I asked some time ago about the demographics of those that had died in hospital. And that is, and you know, what sort of age range, I never know quite how to word it these days, but derivation of the person, and also, has anybody who been last question, last minute I've added, because a neighbour of ours, who I met was in his 90s and not in the best state of health, was vaccinated but subsequently died at home of COVID.
So the vaccination part of that is, you know, if you match up the kind of demographics of the deaths with the kind of vaccination profile of the same cohort, does it throw any light on anything?
So the demographic part of it, the deaths that we've seen at Chesterfield have been broadly similar to the national picture. So on the whole, it's been older people, it's been people with comorbidities, it's been people who have, who are significantly overweight and so on. The number of very elderly patients that have died is slightly lower than the national percentages, but I think that's a reflection of the fact that the national figures are quite affected by the number of very elderly patients who are in care homes. So obviously there was a significant number died outside of hospital, but within the care home. Chesterfield, as you know, has a relatively limited BAME population in numbers, so that's not something that in absolute numbers has been a huge issue for us locally, but on a percentage basis, there's no. I think what I'm trying to say is we're not really any different from the rest of the country. We're not an outlier in any sense from that point of view. As regards the your sad story about the 90-year-old that you know, we know that the vaccine isn't 100% effective. I don't know what the timing of catching the COVID was relative to the vaccine, because obviously immunity isn't instantaneous after a vaccine. So we know after 2 or 3 weeks there's a significant degree of immunity, and after the second vaccination then the immunity is further enhanced. But at no point does is it the case that the vaccination is 100% effective either at preventing catching COVID or at preventing serious complications from COVID. Although all of the evidence is that you're much less likely to, first of all, catch it, and if you do catch it, you're much less likely to have significant disease, much less hospitalisation. There is nationally, and Chesterfield's part of that, an enhanced reporting regime for people who catch COVID after having vaccination, because exactly the issue and concern that you're bringing up, we really want to know whether the vaccine is working, and if it isn't working, are there any particular features for those individuals that might have made the vaccine less effective, so that we can then try to so nationally it can be adjusted what we're doing regarding the vaccine. Does that answer the questions?
Thank you very much, Al. Much more comprehensively than I anticipated. You're obviously migrating from gastroenterology towards the specialty of vaccination. We're well impressed. So thank you for that. And thank you, Norman, for your patience. So you next, please. You're on mute, Norman.
Very sorry. Just to back up the vaccine theme, as keep repeating, I've been working at the Winding Wheel. Now, people do come in with concerns and started asking questions, and I kind of blame the media for that. There is a risk, and I think as Hal has said, and the doctors that I work with there have said it's a very low risk as against catching COVID. But we've had very, very few no-shows with the AstraZeneca vaccine. The only thing that's changed is now the doctors have to speak to people who come in who have had the first vaccine who are under 18. Now they can't be offered an alternative because they've had the AstraZeneca in the first instance. But anyone coming in now for the first one, if it's an AstraZeneca day, are being offered an alternative on another day. But the take-up in Chesterfield is really high. People are not backing away. And we're now getting the first cohort are now coming through. I've been for the last 2 weeks for the second jab. And there's been no slack in that either. Very, very few no-shows.
That's really interesting. Thank you for sharing that, Norman. It sounds like you're doing a great job down there in a busy environment.
I'm trying to.
Well done. I'm going to leave Angie's report there, if I may. Thank you, Angie. And we're going to move on. We're going to go to item 5, which is the quality assurance update from Jane and Krishna. And I'm going to let you know that you're on the promise of a cup of tea after this report and before we go to the next item. I don't know who's leading off. Is it you, Krishna?
It's me, actually, Helen.
Well done,
Jane. Okay. So thank you, everybody, for giving us the opportunity to talk to you a little bit about quality this afternoon. So I've got a bit of an echo back from somebody's microphone might be on.
We'll all go on mute if we may, please, if we're not speaking, and that'll help Jane.
Thank you. So as I said, thank you for giving us an opportunity to just talk a little bit about the work of the Quality Assurance Committee this afternoon, because I think we've mentioned a few items in passing and that we haven't had a long period of time to kind of give you a little bit more information. So please forgive me if some of the items sound familiar. Please be assured that we do have significant assurance on each of these items through the Quality Assurance Committee, but these are the things that we are really working on in terms of quality improvement. So these are areas where we do still face some challenges, and we've got particular strands of work running, and we've also got some deep dive work going. So with that introduction, I'm just going to outline the areas that we're going to go through, and then I'm going to pass over to Krishna and Hal to put some bones on that for you, some detail on the bones of that for you. So the first thing, just to talk about the performance report. So in terms of falls, pressure ulcers and duty of candour, I think you can see that's some really clear narrative and explanation there. And I think we're happy with the progress on each of those 3 areas, particularly given the challenges of COVID. The things that we really want to focus on this afternoon, and we want to talk about infection prevention and control, particularly, as I say, again, in the light of COVID. We want to talk a little bit about maternity and the Ockenden review and where we are particularly with maternity safety. I'm thinking about the champions. A little bit about complaints, and then finally an update, I think, from Hal on stroke. So if I pass the baton over to Krishna to just pick up the first three of those, that would be really helpful.
Thank you very much, Jane. So if I just sort of go through each of those points then, if I start with infection prevention and control, there is obviously sort of from a COVID perspective, there's a national focus, and there's a number of reports that have been published, Health and Safety Executive and from NHS EI for an infection prevention and control board assurance framework, which we had probably 12 months ago. We've had the latest iteration. These two issues, as well as a look back and learning from our outbreaks, has meant that we're pulling together a deeper dive look and a focused look at our next, an additional quality assurance committee. And I think that should give significant assurance to not just the board but the Council of Governors to be able to showcase some of the work that we've done, some of the learning, how we fit in with some of the national sorts of context of outbreaks, where we are and what we need to do. So again, in the line of a roadmap, what things do we need to do with the Chesterfield world to make sure that the high standards that we're aspiring to continue and that we can provide sort of that continued assurance going forward. So that will form a meeting at the end of this month, so in another couple of weeks, where we'll just show where we are and showcase sort of some of the good work that we've done. So that's the first aspect. The other one again is the national focus, and that's from the Donna Ockenden report based on the very sad cases of not just baby deaths but maternal deaths as well at Shrewsbury and Telford, and some of those outcome measures that did show a lack of learning from previous reports that had been published going back many years from the whole maternity services. And we've done an awful lot of work doing an analysis of where we are against those national sort of criteria. We've got to submit evidence to show where we are, so it's a very robust process about what that assurance looks like, and we've mapped all of that out, and we're well on the way from a CNST, which is our safety metrics really of showcasing where we are on some of these maternal indicators. We fed into the national work on that from a CNST point of view, because there would not have been an organisation in the country that would have met those markers, because some of them have been really curtailed, such as training compliance during the pandemic. So they've realigned and reissued what they feel are the safety markers, and we're on board to achieve all of those, which I'm really pleased to sort of say. That's not without a lot of hard work from all the teams involved. The other national focus is on workforce. We've got to submit a bid within another few weeks, so the 6th of May, a bid's got to go up, and that will help us to align some shortfalls and some service improvements that we need to do within our medical workforce as well as midwives. I'm very pleased that we are, from a midwifery point of view, we've just done what we call Birth Rate Plus, which is a national indication of where we are from numbers of midwives that we need to care for the number of births. But not just that, it's the type of mums that are coming through. They're increasing their comorbidities, so if they've got more comorbidities, such as smoking, that will equally potentially need a different acuity when they come to give birth. So with that, we're really pleased that we actually were on the front foot here at Chesterfield. So we haven't got a gap in our workforce. We've absolutely got, we think, measured. We're just getting the final confirmation, but we're there or thereabouts with what we would need to manage our numbers of going through. And that's a very different position to a number of organisations nationally. So that's a really good piece of work that the teams and the K unit had already got on board with. But we're hoping that the funding stream will help support and strengthen some of our obstetrician sort of focus with some of those key points to really to pull together some service improvement for us. We've also got a maternity dashboard, so what you'll probably see going forward in the IPR is some there will be quite a number on there, but they're a way for you to be able to see where we are performance-wise against some of those indicators. So we're just doing the final touches to those, and we're trying to pull those through. So you'll be seeing those in the coming months. The complaints is the final bit I just wanted to update. So I sort of reviewed some of the aspects of our complaints, and I think it's fair to say during COVID our workforce has done a tremendous sort of pulling together and doing absolutely the best that we can do. But within that, when we've actually done a stop check and sort of pause and look back, we've got a significant number of new leaders who we perhaps haven't, you know, if we hadn't have been COVID, they'd have been certainly given a much better support metrics, that a development programme that we've just not been able to do. So in the progress of strengthening that and actually starting that off, and complaints and supporting our ward leaders with a compassionate response that isn't defensive, doing all the right things that the complaints process is set to do. It's about listening to that feedback and making sure that we can take it on board as a way of learning and to change some of the processes that are in place. So we're going to be looking at and strengthening that education and training and support for our ward leaders to be able to ensure. So we've done a look back on some of our reopened complaints, which again has been a really good learning exercise, and actually that's helping to play back into what do we need to do to support all of our responses back to complainants. I think that's all I wanted to say. Just hand over to Hal about from an update on stroke.
Thank you, Krishna. So this is just really an update regarding the situation in stroke. Council will remember that at the end of last year, because of concerns that we had internally regarding higher than expected mortality on our stroke unit, we invited the Royal College of Physicians to come to review our service and to make recommendations really with a view to trying to improve the situation. Quite extensive recommendations, and the first thing to say is that the unit, which has been really fantastically led by Heidi O'Ryan, who's one of our stroke specialist nurses and who's taken over as clinical lead for stroke services, has made fantastic progress in getting through the action plan that we drew up following the Royal College of Physicians report and recommendations. So there's been an awful lot of really good work done, and as a really sort of positive thing, and I guess if you wanted to take one thing home from me speaking at the moment, I would highlight the fact that the mortality data, which there's different measures of it, but what's called the HSMR, which is the hospital standardised mortality rate, for the last 15 months for our stroke patients has been within the normal range. So for the last 15 months we haven't had any concern about increased deaths on the stroke unit, and I guess that's the most important bit for all of us to know and to remember. That said, our stroke service is still a bit vulnerable. We have one substantive stroke consultant and we have two locum stroke consultants in place, which by its nature means that it's slightly insecure or unstable, or I don't know how you want to put it. That's related to a national significant shortage in stroke consultants, and we're doing our very best to recruit, but it's not necessarily very easy. Final thing just to mention, and important to say, that all of this work has been done very much in cooperation with both the Derbyshire wider system, so at the moment Joint of Care Derbyshire Board and becoming the Derbyshire ICS, but also with the NHS England and the regional team, because stroke services, and particularly hyperacute stroke services, is part of a national review process about how stroke services should be configured both locally, so for our particular focus, but also in the wider region. And as a consequence of that, we're now taking part of that review about stroke services and that potential reconfiguration, both from the point of view of our hyperacute stroke unit, but also from the point of view of stroke rehab. So after you've had a stroke, how that rehab works and what needs to be in hospital and what would be better to be in the community and closer to home. So it's really just to make governors aware that those things are happening. We're sort of actively part of that larger process, but in the meantime, to reassure you all that actually the initial concern about mortality that we had is really in a very much better place than it was. So I'll pause there.
Helen, can I just come back and...
Yes, please,
Helen.
Jane. I was just going to say, on the back of that update, which has been really helpful, you might just want to indicate any particular items or areas where you would value thoughts and comments from governors, Jane.
Yeah, can I just pick up from what Hal's just said, though, because all of those areas I think have been significant pieces of work that we've been involved in, and just to assure governors that Quality Assurance Committees continued to run as per normal for the whole period of the last year, and in fact we've had several extra meetings as well to deep dive. So that's just to be clear, we have continued to do everything that we would normally do to keep an eye on the quality of care. And then secondly, just to point out again, with each of those areas, there's been national directives, there are national standards, and those are the things that we use to measure clearly how good the quality of care is at Chesterfield. And some of those have not been without some significant amount of work, actually, from the team. So I think we should say a big thank you to Helen and Krishna and their teams, because actually to have done all of this and to responded in a way that gives us a really clear picture at Chesterfield whilst managing everything else through the pandemic has been pretty amazing. So yeah, I mean, I think we would welcome governors' questions or views on any of those areas. It'd be really helpful.
Lovely, thank you very much, Jane. I'm going to go to Pervez first and then Graham.
Has there been any work done on the teamwork and leadership?
Teamwork and leadership, do you mean in these particular areas like maternity or stroke, or do you mean more generally?
Just stroke.
Just stroke, yeah. Do you want to come back on that?
So the clinical lead for stroke now, I mentioned her earlier, is Heidi, who's one of our stroke specialist nurses. And she's been fantastic at working both internally and with external partners, both to the north with Sheffield and South Yorkshire, but also with Derbyshire and East Midlands, and she's been a real star from my point of view. There's also been quite a lot, I mean, on a personal basis, I've provided quite a lot of leadership and support to the stroke unit and those wider discussions, because one of the issues that was raised by the Royal College was that sadly there was a bit of a lack of leadership from the medical consultants within the stroke unit, and so there were some issues, and we're doing our best to support people with that. But I think we have to also acknowledge that leadership isn't for everyone, and if people aren't wanting or feeling able to do that, then we have to work around it a little bit rather than trying to put people into a position that they don't feel able to fulfill. So hopefully that gives you some gives a bit of an answer to your question, Pervez.
Thank you very much, Hal. Graham, please.
Just a quickie, deep dive. How does that differ from anything else, or are we talking of swimming pools and how far we can get down before we take a breath? It was just a point of clarification, please.
Shall I start? We have a certain number of quality assurance committees, Graham, through the year. That's a kind of set, it's not quite quarterly and it's not quite bi-monthly, but normally 5 meetings. what we've found from doing the committee review is that where we've got something that we particularly want to understand in some detail, it's helpful to have a single focus meeting. So we've had we've had one on ethics in the last year. We had one on maternity, and we're having one on infection control. So it's basically just our term, and I do apologise again, it's jargon, isn't it, for a very focused meeting. So it will be a single agenda item, and we will probably spend between 1 and 2 hours, the normal members of the Quality Assurance Committee, examining that item in detail.
And there's no requirement to wear your swimsuit to attend the meeting, you'll be pleased to hear.
I was getting worried, I thought, what's happening? But no, that's fine. Yeah, it's just a more detailed look is what you're talking about. But yeah, thank you.
Greg, you had your hand up.
Thank you very much. Good afternoon. I would concur with Jane. I think Helen Krishna's work, especially over and above all the work with the pandemic, has been. My question is to Krishna. It's absolutely brilliant that you've identified no gap in the maternity workforce. Could you just clarify for the meeting your comment about comorbidities of mums? Are you saying that comorbidities in mums are increasing, or that you have a team that can cope with increased comorbidity?
I think I've got the gist of it. I'm really sorry, Greg. I was struggling to hear. So I think this is about comorbidities of mums. So this is seen nationally. The pictures of mums. If you smoke, if you're more overweight, as well as any underlying health conditions, then by virtue of that, then your birth, if you like, is generally not as straightforward. So we've definitely seen during COVID nationally more caesarean sections, emergency sections. We've seen babies born before term, and sort of a slight increased sort of usage on our neonatal unit. But we're not an outlier, but that is generally the case, that you've got mums who need more of a look, so more frequent scans, more frequent checks. It's that type of thing, and wherever you've got the same number of mums, but they're needing more interventions and support to be able to support them through that pathway to ideally have a natural birth. But that's what I meant. So sorry if there was any sort of confusion there.
Well, that's much clearer. Is that a result of the pandemic, or do you think that is separate from the pandemic?
A bit of both. Certainly during the pandemic, there's definitely been women who have sought help later on, or not sought help when they needed to. So there's been a reticence to get some sort of support. But nationally, before the pandemic, there was an increase in interventions required to support women. Sort of smoking is one of the highest risk factors, and we do know that women in the north of the county have a higher degree of sort of a smoking pregnancy than other places. So it is a particular hotspot for us.
Thank you very much.
Thank you. Lynn, please.
Thank you, Helen. Krishna, I just wondered if you could explain a little bit to us about how much education the maternity department does with mums, particularly around things like smoking, and I'm assuming that alcohol as well is included in that, and whether there's any sort of specific education that is given, or whether it's just leaflets that are handed out.
There is a lot of, throughout the pathway from the midwifery side of things, there is various sort of checkpoints in with mum that will go through the various risk factors, and wherever any risk factors are highlighted, such as smoking, then that is additional time spent with mum, or it depends what the response is from mum. If they're wanting support, then we would put them in touch with somebody who can spend more time with them. So there is that education and interaction with the mums right the way through the sort of the pathway. One of the things that we do know, sort of from a national point of view, and that does link into continuity of carer, which is a small team, sort of up to 8 midwives who've got a geographical area of mums to look after. that there's a response and a rapport with that midwife and those mums that makes it easier for mum to get support, have continuity with that midwife right the way through all the antenatal, right the way through the birth and into sort of after they've had baby. And that has definitely, we've seen some of the evidence base of is that you generally, because you've got a rapport with the midwife, you will generally sort of take up sort of quantities of care, whether that be smoking cessation, eating better, you know, a whole raft of things that are health markers that will support mum baby. So continuity of care is we've had our first group set up in January, and we're working really hard with the teams to get our second team set up sort of midway through this year. But that rapport is something that it's the education that really should be ongoing, but it's just easier when they've got much more of a rapport with the midwife. And that's something that we're trying to support along with the national sort of to do that. It's a better outcome for babies. Does that
Yes, thank you very much, Krishna. Just to say a huge thank you to Jane and Krishna. Obviously, there's been a huge amount of work that's gone on in, you know, otherwise demanding circumstances. But, you know, frankly, you can't afford to take your eye off quality at any point, can you? So, you know, very, very well done. The next item now, which are the issues from the governor's pre-meeting. And as you know, we put our executive colleagues on notice of those with a brief note earlier, and we've had the opportunity to cover two of the themes that came up. One was around recovery, extended hours, and other ways of catching up with the backlog, and with a specific around ENT in that regard. And we've agreed that we're going to have a paper, a substantive item on the next agenda. And then there were a little clutch of issues around vaccination and efficacy of different vaccines and the risks associated with them. And then, of course, the particular one around, you know, vaccination vis-a-vis timing of protection. So we've done all of that. And as we always do, we will attach the full list with the responses to the minutes. So I'm only proposing, really, that we take one further theme that emerged in the pre-meeting now, with your permission, which is the one that Norman raised with us really helpfully about, and it gave a very rich discussion, and it related to a constituent who had been an inpatient and was on a ward and in a bay with a gentleman who had some difficulties with drug addiction and some difficult behaviours as a result. And in raising these concerns and issues with the trust, he got a response from three different responses from three different matrons relating to the same issue. So that raised three areas of discussion. The first is about the complexity of care when mental health issues abut physical health issues, and how it is we look after everyone who needs care, but in a way that best respects the needs of others who are being treated at the same time. So we had a good discussion around that. We then had a discussion of whether we liked the old-fashioned or the more modern definition of the word matron. And, you know, there was a time where there was only ever one matron in a hospital, and now, of course, in Chesterfield, we call our kind of leaders of the ward area a matron. And there was a question about, is the nomenclature right? Does it convey what we're trying to convey? Yes, issues in that regard. And I suppose the associated issue was, whatever we call them, have we got real clarity of roles and responsibilities? And the third area was around the complaints process itself. So, you know, we may not have an issue about clarity of roles and responsibilities, but maybe we have a weakness in the complaints process about the adequacy of the coordination of complaints going in, the commissioning of replies, and the polishing of them prior to dispatch, so that we don't come up against those problems. I haven't done justice to that conversation. As you can imagine, there were a whole range of thoughts and issues. But I do think it's important that we pause for thought around complaints handling, because those more long-standing members of the Council of Governors will be only too well aware how hot a topic complaints was for many years. And we've made such fabulous progress in terms of the timeliness and quality of our response to complaints that this, of course, may be a one-off, or it may be an indication that we need to be a little bit attentive now to the kind of end-to-end complaints process. So, Krishna.
Thank you. Can I answer in reverse order? So the complaints process, I absolutely agree with you. And that sort of goes back to sort of my earlier conversation. When I've sort of seen some of the complaints coming through, there is a bit of we haven't got that overarching sort of look and making sure that we've got that consistency and who's taking charge for that. So we've got a lead investigator, but actually the division needs to have more of a say in, because they need to sort of manage that expectation and manage sort of the response. So one of the changes is that the heads of nursing will be that lead responser and do the quality assurance for all of those responses coming through. So if there is a fragmented response, and that won't go out, that needs to be taken back in the conversation had with the variety of sort of people who've responded. So I do believe that that will get better, but it'll take us some time to hold those forums with our senior leaders to get that sort of consistency going. I don't think the responses in general are bad, but I do think we've got room for improvement. We absolutely have. And for me, the area for improvement is a bit more of a compassionate sort of response in some ways. There is still a bit of a defensiveness, not in many, but in some sort of areas. And I've already had those conversations sort of with my heads of nursing about, but that isn't good for anybody. Somebody's taken the time and the trouble to alert us to something that hasn't gone right in their view, and it's up to us to be able to put a respectful response back to that person, where identifying any learning that we can have, and through that learning, what we've said is that will come through our governance forums as well, so learning from complaints, learning from incidents. And to be fair to the teams, during COVID that's been particularly difficult to pull together, because we've all been really sort of focused on maintaining the safety of the patients, and that's an area that we've got now time to really refine and move forward with. You raise a really interesting comment about the word matron that I'm struggling with myself. So I've already had initial conversations with my heads of nursing about what does that mean. I think it causes confusion. I think we have too many, because there are ward leaders that are called matrons. That doesn't fit with the national guidance that we've had. We had a matron's handbook that was released from our Chief Nursing Officer, Ruth May, over about 14 months ago. And that is an expectation for the matron that will oversee a number of areas. But our matrons see themselves as they should be doing all of those things, which is not being supernumerary and having that oversight, and they can't do that. So the expectation is wrong, really. So the national expectation with the word matron and how we're using that within our teams on the ward as matron is causing confusion. So that is one of the, it's the timing of that, because our ward teams are very proud of the word matron. It's got different connotations for different people, but fundamentally they're proud of that word. But I think it causes confusion. I don't think it helps if we go out to a Band 7 post externally, because people don't understand what they're applying for. They think that they're applying for a different position. So it's not helping us to attract people externally into the organisation. It certainly is leading to confusion about and lack of clarity internally. So there's definitely a piece of work there that we need to do. And we've already had conversations about how we do that. What we call the current matron title going forward, I think needs to come from themselves as to what they feel that is, and that will be a number of workshops that we will do with the Band 7 ward leaders as they currently are. That leads into roles and responsibilities is not clear. That's part of the work that we're starting to sort of to do now, is about reviewing the job descriptions, which I've already done, doesn't give clarity of role. So we're reviewing the job descriptions with our ward leaders, our current patrons, so that we can be very clear about what that expectation is. And that will lead into the wider sort of development and support for them to be the excellent leaders that they want to be, and that we've got time to do and support them in that journey of excellence. Because we were quite surprised when we did the number of, so like 60% of our Band 7s, our matrons, have been in that post within the last year, with very little support because of the circumstances. So we know that we've got a lot of work to do to redefine what that role is, the title, and looking at the roles and responsibilities. Does that help? I've just seen Luke, I've just seen in your comments, yes, it does cause confusion internally and externally.
Enormously helpful, Krishna. Thank you very much. And you can see the richness of the conversation Norman, Tom, Michael and others have prompted. So thank you. Really good. Oh, Angie, you've got your hand up.
Come off mute. A small point, but an important one. When Norman said the person had received 3 different responses from 3 different matrons, was that a verbal complaint or was that a written one? Because what Krishna's described gives us a framework to address that inconsistency, whereas some patients and relatives will say they've complained, but they've done it informally through PALS, which is a harder one to address, but something we need to be cited on in terms of giving support to matrons to be able to respond consistently to those informal ones, if that makes sense.
Yes, thank you, Angie. When I raised it this morning, and I've looked back, because following up the conversation, my colleague, or the person who spoke to me, actually sent me an email, and I'll just quote if I may. I felt very strongly about what had happened on the ward and made my concerns known to the hospital authorities after the incident that I experienced back in December, which was followed up by 3 apologetic phone calls from various matrons. So it's 3, when he says various matrons, I don't know if he means 3 matrons or 1 matron with 3 calls. So I will clarify that for you, Angie. Because I think it's important, particularly when there's complaints.
I clarified it already, Norman. So I'll pick up with Krishna in terms of a bit of support about how we deal with that. That's really helpful. Thank you.
He did, in his complaint, he did say that the hospital managers, and he's highlighted, must address issues such as these before a fatality occurs or before a patient or their family brings a legal case against the trust for negligence. I fully accept that everyone has the right to treatment, but is it right that an addict and antisocial behaviour issues can bring about such chaos and put the lives and recovery of other patients at risk? I do understand that everyone deserves treatment, but so do the other people on the ward, if you like. They deserve the correct, I would say, treatment, yes.
Thank you very much, Norman.
Thank you.
Very good. We're going to move on now, if we may, please, to item 7, which is governor feedback. And we thought at this meeting it would be really helpful if Mike would give us some feedback in his capacity as the COG representative on the urgent and emergency care capital scheme. So the floor is yours, Mike.
Thank you. First thing I'd like to say is that at the last project board, which was end of March, both Beverly, who is the board, and Ned's representative, and I, as the COG representative, expressed our admiration for the process, really, and the progress that had been made in what is now known as the Urgent and Emergency Care Department. And if all goes to plan, the enabling works, which is, the drains and the gases and the water and electrics and data and stuff, should begin Q3, which is sometime at the beginning of October of this year. And after that quarter, the main construction of the department should begin early next year, with a target completion of October or autumn 2023. And that's a year earlier than the original plan, or thereabouts. Beverly and Lee's gone now, and Berenice and others may correct me if I've got a few details wrong. But I thought particularly for the new governors, it might be worth just going back over the history of the original emergency department, or A&E as it was called then. The new Chesterfield and North Derbyshire Royal Hospital opened in April 1984. I think it was on April Fool's Day. It was what was described as a Best Buy hospital, which is sort of off-the-shelf design, of which Rotherham was another one. And I think something like Grimsby was also similar. And as a result, some of the things that were designed were not really fit for purpose, and from the day one. And I think that probably applies to the A&E department, which was designed for about 40,000 patients every year. Now it's nearer 90 to 100,000 patients a year, attendances a year. Obviously, that's affecting the 4-hour wait. In fact, the determinants of a 4-hour wait are the number of patients who go in and the patient flow on the way out. And if you really had an effective patient flow, you might not need to increase the size of your emergency department. But of course, we have had problems with patient flow, as I have been banging on about for a number of years. And I'd like to pay tribute to Tony Campbell, the former Chief Operating Officer, and his deputy, Mike Hayward, who really took this on board, and patient flow has improved no end in the last few years. So the plans for what was going to be a new urgent care village, which we all thought was a rather strange name for it. Villages have churches and pubs and petrol stations. Actually, petrol station might be not such a bad idea if we want to generate a bit more income. Anyway, that has been recently abandoned. The plans started almost a decade ago, but really started firming up in the last 2 to 3 years. And the idea was that the urgent care village was all going to be within the footprint of the existing ED. And interestingly, it was going to be rebuilt while maintaining services, which I imagine would have been an absolute nightmare. Completion was due probably around 2024, and NHS, E or I or both were going to provide £19 million towards it. And then COVID struck, and it became clear immediately that there was insufficient space in the urgent care village if separation of COVID positive patients and others was going to be maintained. So thankfully it was decided that a new build on a separate site was the only answer. And the site chosen was what is referred to as the consultant's car park, but it isn't just the consultant's car park, and it also involves the link road to Scarsdale. It was going to cost more, completion was going to be quicker, there's going to be some loss of parking and some road closures. Now, I've got a picture, you'll be able to see it, but it's back to front. I don't quite know why it's back to front on there. Thank you. Sorry, tea's just arrived.
Is that your spangly assistant? We're very impressed.
Yes. Anyway, you can't see a thing on that. So I thought I would draw a simplified version of it, and it's still back to front. But the diagram, basically, you will see there are 3 sections. 1, 2, 3. The lower one is the south, The south one is the walk-in area, which consists of DHU, reception, mental health, paediatrics, and minor treatments. And then the middle one is for resus and pit stops, and the top one is for majors, and there's a division line, a separation line there, where it is possible at the time of pandemic to separate COVID patients from or suspected COVID patients from non-COVID patients. Now the entrances, I don't know whether you can see this at all. Remember it's back to front. There's a corridor from the main this is the ambulatory entrance for pedestrians, and there's a corridor to the main hospital. Then here there are entrances for resus and also green patients, and up here are entrances for ambulance. These are all ambulance for red patients, in other words, suspected COVIDs. I think that's probably all the information you're going to get from that. Now, the first floor is mainly plant room, but on the south elevation of that, there's a room for staff accommodation, including seminar rooms as well as changing rooms. There's a provisional plan to expand that, and I think there's enabling work so that could be done at a later date. There's an issue of cost here, and that is that the expansion of that to what the department really wants is going to compete with the cost of a third CT scanner. Anyway, paediatric assessment unit will now be on Nightingale. And there's a question of whether 6 beds are going to be lost during the works, but I don't know many more details about that. And the cost ceiling at the moment is about 23.5 million. So there are not many advantages to the COVID pandemic, but one of them is that we will have a much better emergency department than we would have done if it had been done on the same footprint, and it'd be far less disruptive. So various questions have been asked to me by other governors and other people. The old emergency department, no decision has yet been made about use to that. There have been several claims to it, but no decision has been made. The car park for A&E is going to remain. I'm reassured that there are adequate waiting areas within the department. It's not immediately obvious from the plans, but I've been reassured many times. And hopefully it can all proceed on time. And if Beverly and Lee and Berenice have got things to add, I'd be very grateful.
Well, we're very grateful to you, Mike. You've given us a real flavour of where we've come from, the twists and turns, and where it is we're headed. So not only helpful for new governors, but a nice reminder for all of us, really. So thank you for that. Norman.
Mike, you mentioned a kind of a standard build when the hospital was built. Is this A&E? Is this another standard build, or have the people who currently work in the A&E at the Royal, have they been consulted in?
Yeah, absolutely. Yeah, absolutely. There's been a huge input from all levels of staff, including Catherine Lendrum, who is the lead consultant in the ED for this. It is not off the shelf at all. It's entirely bespoke.
Good, thank you.
Beverly and then Berenice, please.
Thank you, Helen. Just endorsing Mike's comments, actually, the work that the staff around putting the plans together is quite remarkable. As we know, ED is an incredibly pressured part of the organisation, and Catherine and others have gone to great lengths to engage everybody to make sure that all aspects that feed into ED are consulted. It's a shared vision for the flow. And just another comment when Mike mentioned about taking the staff facilities upstairs. So the project board has decided at this stage we can build the foundations such that the entirety of the top floor can be built on. so smooth as well, should we ever need additional space. So fantastic job. I am so relieved that we are not refurbing the LDD, because the logistical challenge of that was beyond imagination.
A nightmare.
Thanks, Beverly. Berenice.
Thanks, Helen, and thanks to Michael for that kind of outline that you've managed to cover. And again, it's a little bit disappointing that Tom's saying you've taught me a few things when he works within the department. So clearly there is more to do on engagement. So I just wanted to mention that we have developed an engagement strategy, a comms and engagement strategy that is being built on, because what's important now that we've kind of got an agreed outline where staff have been properly consulted, that we start to be able to visualise it. So we are planning on doing kind of sessions with staff to be able to talk through, so that they can see what things will look like, and where things will actually be placed. Which will just help, because people understand it, don't they, in different ways. So I think that'll be a real bonus. The other positive is that we took the staff accommodation, the additional staff accommodation, through finance and performance meeting as well. And so we have got agreement to put that within the options, just to get the guaranteed maximum price, to have that looked at as well, just so that we understand from that perspective as well whether we could get that in place within the envelope that we've already allocated, which will be a massive bonus to us as well. But great work that everybody's done on it. But, sorry, the final bit I just meant to mention, Helen, sorry, is that we have now appointed a programme director, which will really help move this forward, because as Michael said, we want to move at pace now, and we want to get this completed earlier than we're actually expecting, rather than later.
Very good. Who have you appointed, Berenice?
A girl called Lauren Leverton. She has previously worked in urgent and emergency care in an acute sector, but has previously been leading on the same day emergency care work at NHS England. So, yeah.
Thank you. Tom.
Can I just clarify that my lack of understanding is that I find blueprints very difficult to. If I look at them for more than about 30 seconds, I get a migraine. And Michael's simplification of the plan, even though I couldn't see it desperately well, was a revelation. And I kind of wonder if that's one of the things that we need to do, is have a simplified version of the blueprint to help people to visualise it.
Yeah, we are pulling that together, Tom, and we're also pulling together a bit of a fly-through, so that you can actually see the department and what it'll look like, which it'll help as well contextualise it. Thanks for that clarification, Tom.
I'll patent it and send you a copy, Tom.
Can we go to Luke, please?
Yes, thank you. And I guess it's really just to keep on the focus of engagement. And when I met Berenice the other day for something else, this project came up in conversation, and it was particularly, seen as I'm representing the allied health professionals and pharmacists and scientists, it was good to know that that non-traditional workforce in A&E is also being recognised. So where will they add value to the patient and the pathway? So that's really good to hear.
Very good. Thank you for sharing that. Lynn.
Thank you. Yes, I just wondered, I don't know whether it's because I'm watching this on an iPad, but I actually can only see 9 people at any one time. So I didn't actually see any of the plans that Mike was presumably holding up. And I wondered whether those plans could be sent out to governors.
Great idea. We'll pay Mike the suitable royalty, and maybe put the bells and whistles on it that Berenice is promising. So
yeah, don't pay him too much.
Don't know that you'll be able to afford it.
Yeah.
We'll share that.
Thank you.
Shortly. Thank you. Very good. Well, thank you again, Mike, not only for the update, but of course, you know, you and Beverly kind of deserve a long service medal, really, don't you, in terms of the length of your attendance on this particular endeavour. So we're very grateful to you, and thank you. And that brings us on to the staff survey, please. The staff survey is probably my favourite topic. I have encouraged Zoe to be brief in her introduction, which she's given me a thumbs up on. So thank you for that, Zoe. And not least of all, because I'm sure, you know, please don't sell us short on some of the fabulous headlines and the one or two areas of challenge we've got left. But I'm sure governors will have lots to say and ask. So floor is yours.
Thank you, Helen. So these are our 2020 results. The embargo was just lifted last month, hence this is why they're coming now. I won't say too much about the detail. Clearly last year was a very difficult, challenging, uncertain time for everybody, so tricky to know what the results are going to say. I think particularly in that context, overall, they're a positive set of results, and we've continued the improvement we've seen in the prior 2 years in terms of our staff survey results on the whole. The paper does have all the detail in terms of the themes and the questions, so you can see the areas where we've continued to improve and the areas where we still need to do more work, so violence and aggression being one of those areas. I just want to say a little bit about what we're doing now and next steps, so governors are aware of that. So the results have been shared, and the local team results have been shared with local teams. The conversations are ongoing at the moment in kind of wards and departments, and that will continue over this month and into next month to gain input from local teams and develop, you know, what needs to be done in particular areas, because all teams are different. So not all those conversations have happened as yet, but they are ongoing. And on a trust-wide level, this year we're focusing on two key themes. So one around health and wellbeing and one around values and behaviours. They're quite big, I appreciate, so there's lots and lots of detail under there, which the People Committee are well cited on and will have oversight on throughout the course of the year. And the work that we're doing does align as well with our people strategy and the sort of system people plan and the work we're doing across the system, and also national expectations around plans coming out nationally too. So there's quite a lot happening, I guess, planned and happening around what we do with the results. So, you know, it's great to get them, but the important bit is to say what do we do next. So I will pause there, and I'm sure there'll be questions.
You have to, of course, spare your own blushes in terms of, you know, just saying what an important role you and your executive colleagues have played in showing the leadership that's given us this quality and fabulous results in a very difficult year. I'm sure if Jeremy was here, he would lead the charge as chair of the People Committee in saying just that. So please accept those thanks. It's been very hard won over a long number of years to get us to this place, and I was very concerned that COVID might have set us back, but I think relatively speaking we're kind of continuing to progress, which is very encouraging. Just before I come to Tom, I'm conscious that we've got Atul on the call, who's also a member of the People Committee, so I don't know, Atul, if there's anything you want to add.
Well, I think it's just really been amazing how everybody's coped, and we've still, you know, found the time to fill in these forms. I'm sure, you know, there's tons of stuff that people would have been having to do on a day-to-day basis. The results, I really think are exceptional given all the circumstances. Of course, it would be even better to have had more of a response and improvement in some other areas, but we've got to have something to do in that sense. And I think the couple of areas that Zoe's picked out as things that we need to attend to, you know, will be watched over within the People Committee at least.
Thank you very much, Atul. Tom.
I'll say first of all that I find the survey results encouraging on the whole, but I think they need to be interpreted with a certain amount of caution for two overlapping reasons. Number one is the fairly big drop in the response rates, you know, and I just wonder why. It was possibly due to the pandemic itself, and as you say, people being busy and concentrating on that, but you know, sometimes the people with the extremes of views are the ones who sometimes will exclude themselves from the process first. So, you know, that's my first caveat. And my second caveat is we need to remember that this survey was done fairly early on during the pandemic, when the Battle of Britain spirit was very much there. As an ex-RAF person, I tend to refer to Battle of Britain spirit rather than Dunkirk spirit, but, you know, bear with me. And I kind of think that things might be rather different if it was repeated right here and now, you know, because a lot of the Blitz and Dunkirk and Battle of Britain spirit is starting to, you know, to weaken somewhat, shall I say. So those are just the, you know, the two cautions that I would lump on it.
Thanks, Tom. Shall I answer that now, Helen?
Well, I just hold on a moment, so we just see if we've anybody else. Anybody else like to come in on this item, and then we'll give Zoe the last word. Margaret.
Just a question, really, not so much about these results, but about the future. If I read the report correctly, it says that next year's survey is going to be different. I just wondered if you could just sort of give us a heads up as to, do you know yet what the differences are going to be? Because going back to Tom's sort of interpretation, when I was doing the staff survey myself, it was always frustrating that there's no opportunity to put a narrative behind what you're actually asking, and I wonder if that's going to be any better in the survey that we'll be doing this year.
Thank you, Margaret. Hold that thought for a moment. I've seen Norman also wanting to come in.
Just as an aside, really, that I know it's not part of the survey, but I do monitor the Facebook site for the hospital, and I note on there the amount of staff who've been working extra hours, if you like, on different wards, etc., saying what a wonderful place it is to work, what a fantastic hospital Chesterfield Hospital is. So I somewhat agree with what Tom says as well, you know, was it the right time, etc. But the enthusiasm is still there, and I hope that runs through the hospital and not just individuals. It's difficult to gauge people's feelings during times like this, and I think now that the government's just thrown this 1% pay rise in, it's, well, if they can't bother, why should I bother? You start to get that attitude, I'll just do the minimum work I've got to do, and we'll leave it at that. And if they want me to fill surveys in, well, they'll have to pay me to do it or whatever. So all these things come into the mix, and I think we need to be cautious, and I agree with Tom, not to to make sure. I think if we did it again today, I'd agree with him, we might get a different result. Thank you.
Thank you, Norman. Pervez. You're on mute, Pervez.
Can you hear me now?
We can, thank you.
Well, if we look at the history of the hospital, we've been very much work and finance oriented hospital for decades. And there are lots of people who have spent their entire working life in the hospital, including me, Mike Grunman, and a number of other colleagues. I think culture is changing. We are attending to the softer aspect of the workforce and care about their quality of life and what they get out of hospital as compared to what hospital tries to get out of them. So we need to address these historic issues as well and make it more humane and quality hospital.
Well, hear to that, Pervez. And I think, you know, the fact that last year we were the most improved trust in the country for that section that are surveyed by Quality Health bears great testament to the progress we're making on that very important journey you describe. So with all the caveats people have given, we need to make sure that this continues to go in the right direction, irrespective of the time of surveying. But, you know, be assured we're very committed to doing just that. Last word, Zoe.
Thank you. Let me know if I've missed any of the questions in this. So response rate, yeah, you're right, Tom, it is quite a lot down from last year. Just Sue's comment in the chat box as well. We had a number of conversations during the survey period around that. Previously, as you know, we've been very proactive in terms of encouraging people to complete it. We purposefully took a more measured approach this time around because of the context of, you know, how everybody was in the pandemic and how everybody was working at that time. So we were, I guess, aware of that and conscious of that, and I guess not surprised. It's still a large number, although it is down quite a lot from last year. It's still certainly significant. Hopefully things will be back to as they were this time around. We will see. Timing wise, so Angie talked a bit about morale at the beginning. I would echo and agree with what she'd said when you sort of touched on there as well, Tom. The survey was carried out, or the bulk of it was October, November last year. So I would say we'd come out of the initial Battle of Britain, not Dunkirk, spirit at that time, and we're in a different phase of the pandemic because we've had a few, haven't we? We've had a few ups and downs as we've continued through. So except we're in a different sort of feeling now. I think we were in a different feeling in October, November than we were kind of April, May also. And the future survey, so no, Margaret, I don't know what it will look like this time around. I fully expect it'll be aligned to the people plan, so in terms of the key themes coming out of the people plan, but in terms of size, number of questions, how much narrative, how much free space, we don't know yet.
Thank you very much, Zoe. Onwards and upwards, and thank you again for all the leadership you've shown around this. I'm going to move us on now to the review of the draft Council of Governors section of the annual report. You've had a draft, and John, if you just introduce the item for us, please.
Yes, thank you. It's basically as part of the annual report, we have to include a summary from the Council of Governors, and the majority of that is with the papers. There is one or two bits that we haven't yet been able to include, which is basically the staff data bits, which we're still waiting for, but we'll have those in a few days, and Nick has said she can share them out, send them out to people to look at when they get through if they wish. But basically, any comments on the text that's there currently?
Very good, thank you. Are you content with the text as it's set out, or are there any amendments you wish to offer? It's obviously been through committees, so I think it's safe to say that I think I'm seeing people are content. That's a nod from Margaret. Very good. So thank you for all your hard work and your team's hard work. It's a very busy time of year getting all of these reports in the shape they need to be. So you've done a lot of work and we're very grateful. So thank you for that. The rest of the items on the agenda are either consent items or items for information. So we've had no notification of anybody wanting to raise anything under consent items, and the items for information you can see. So that brings us to the review of the meeting. So either in the words of the great prayer, what have we done or failed to do, or even in the terms of the behaviours described in Leading the Chesterfield Way, have we role modelled them or not? So thoughts on today's meeting, please. Mike.
Me, Mike? Or other Mike? Sorry.
Oh, it was Mike Killick's hand, I saw.
Sorry, yeah, good. Yes, it was my hand up. Yeah, no, listen, I've dropped in and out a couple of times, which is my silly fault, but I'm, given where we're at with all the work that the execs have got, and given all the debate we've had with the Neds around recent dialogue, it still never ceases to amaze me how much effort and focus and time and energy the execs in particular, and my Ned colleagues, and of course the governors put into these meetings. They're incredibly important, particularly with all the backdrop of the ICS, where I do think the government is missing a trick here somewhere in proper involvement from the governors, and it's really pleasing to see that that's not affecting the input from our governor colleagues in particular. So I just think that these are very important, interesting, informative meetings, and I always drop off thinking, yeah, I've learned a lot more again today, and that's exactly how I feel right now.
Thanks, Mike. Very helpful. Any other comments? Sue?
Thanks, Helen. Yeah, I just wanted to thank governors for the richness and variety of comments and feedback. It's a really important meeting for us to get that insight and to get all of those perspectives. So I just wanted to say thank you for that. And yeah, and also as ever, I would be the one as also a member of the People Committee, just to say a big thank you to Zoe and all of the exec for those great staff survey results. That's me. Thank you.
Very good. Last word to you, Margaret.
I've just typed in the box. I just think it's been a very good meeting as usual, and everybody's had a chance to contribute and lots of useful conversations. So yeah, it's been good.
Very good. Thank you very much for all your best attentions and participation as ever. And we will, I will say when I see you soon, we may indeed see some of you face to face, assuming all continues to go according to plan. But as ever, stay safe and thank you very much.
Thanks, Helen.